And now is the moment to glean the views of other key stakeholders at the forefront of cardiovascular health. We are very honoured that Professor Lale Togosogulu, past president of the European Atherosclerosis Society, has agreed to moderate this session, and I would like immediately to give the floor to her. Lale, please.
Thank you very much. So welcome to the panel on FH screening in Europe, where we will move towards a consensus with the key stakeholders. We've been discussing that FH is vastly underdiagnosed and undertreated, leading to early cardiovascular events. And since WHO recognized it as a public concern, there have been positive efforts from different stakeholders, and a call to action was published last year with international coalition. But now is the time to come together for a systematic approach in Europe to preserve the health of future generations. Today, we have distinguished representatives from the key stakeholders. Joining us today is Professor Kasi Cray, President of the European Atherosclerosis Society, Professor Raul Santos, President of International Atherosclerosis Society, Professor Fausto Pinto, President of World Heart Federation, Professor Martin Halle, President of the Prevention Association of the European Society of Cardiology, and Dr. Gutierrez Ibarluzea, WHO Technical Advisory Group and past President of Health Technology Assessment. So without further ado, I'd like to start our panel. And the first question I want to discuss is by hearing the panelists' perspectives on the importance of screening programs. And I'd like to give the floor first to Professor Ray, because he has published the world's largest registry on FH. Please.
Thanks, Professor Togosoglu. So I think what we've done with the global registry, the first aim was to try and understand, this is a genetic condition. We've got a fairly good understanding of the prevalence, 1 in 311 globally. In certain regions of the world, it's more frequent where there's consanguineous marriages and so forth. But the key message is that if you look at a condition that occurs in every WHO region of the world, it's diagnosed after 45 years of exposure have been missed. That's the average age at which we are diagnosing these individuals. Moreover, when you look at the age of diagnosis, the later the age of diagnosis, the more likely it is that people have had something bad happen to them, whether it's a heart attack, a bypass operation, a procedure. And these are only the people that have survived long enough to be able to get into the registry, and doesn't even include those that have died before. Very few children are identified early on. So if you look at people before the age of 20, less than, in our global registry, less than 2% are in that particular category. The next important thing about this is we lose the opportunity to change behaviors and reduce the likelihood of additional risk factors developing. Because yes, the main driver for heart disease will be high cholesterol present from birth. But the later the age of diagnosis, the more common are additional things like high blood pressure, like diabetes, like higher weight. That basically means those 40 years where you've got a very good opportunity to course correct, not only to start cholesterol lowering treatment, but to encourage lifestyle behaviors is lost. If you look at those people in our registry now who were identified because their family member was identified, because the age of those additional people is lower, there is less likelihood of cardiovascular disease and also risk factors. So we know that actually identifying people means that they are less likely to have things wrong with them, less likely to have risk factors. So what that consistency of that message is telling you is time. If you now move to the children, and you've seen this already, that of the global data that we now have, like 12,000, 13,000 or so individuals, the vast majority are found as by index, as an index case, meaning that something bad had to happen to their mother or their father for them to be found. And that is morally wrong. We should be finding people systematically in a way that we can change their life course, and through reverse cascade testing, maybe also help their parents. And we often think about these things like screening and identifying, thinking that, you know, it's going to be a budget item, it's going to be a cost. If we are really to be serious about preventing this condition and its consequences, we need to think about preserving health and not treating disease, which is what currently we're actually doing. So with that, Lale, I will hand back to you.
Thank you very much. Now I'd like to have the perspective of Professor Santos, please.
Good afternoon, everyone. Nice to meet you all. So as has been shown before, we have a condition that is genetically determined, that we can make early diagnosis, we can implement efficacious, safe, and cheap therapy, and we can make a lot of difference. So in my opinion, if Europe starts really this process of making pediatric diagnosis as, let's say, a rule, Europe can be an example to the rest of the world. I represent a society that actually focuses mostly on the health of people outside developing regions. So developed regions. So I think that if we learn from what is being proposed here, and we can expand this with simple measures, I think we can make a lot of difference. As Professor Ray showed, the registry shows a huge gap in different areas of the world. And certainly in countries like mine, we have a greater gap. So basically, we have to learn from the examples that have been shown and really expand the possibility of really making the difference. And as I said, the therapies for most of people with FH, it's been already with us for more than 30 years. They are safe and they are cheap, they're inexpensive, and they can make a lot of difference and really save lives, save costs. So I think this is the example that must be set for the rest of the world to really make the difference for all of us, and especially for our children. And definitely, I think we will change the face of this disease forever if we're able to start very early. Thank you very much for the possibility of being here.
Thank you. I certainly hope so, Rao. Kosh, did you want to add something?
Yeah, so I really want to echo those last sentiments. So I made the point about thinking about investment and thinking about this as an opportunity to basically prevent and invest and get a return in the future. The one way to think about this is, if you find people age 40, 50, 60, think about this as pension and when you are going to retire. If I've never saved my entire life and I start to think that in 10 years I'm going to retire with a good pension, I'm going to have to put a lot of money away at that point. So basically all those people that we find much later in life, we often think about, well, am I going to be using lots and lots of expensive drugs and treatment? If you find people late, then you probably will have to course correct. But if you start early, it's like saving for a pension very early on. The earlier you start, and we have cheap, small treatment, you will get that compound interest so that you can retire in good health. That was the only thing I wanted to add, Lalette, which I forgot.
That's a very important point. And now the perspective of WHF is, of course, extremely important. So I'd like to hear from Professor Pinto, his perspective.
Well, thank you very much, Lali, and good afternoon to all the panel and the audience. And it's really been a fantastic day. I think we have to congratulate the Slovenian presidency for putting together this important meeting. And as Sir Geoffrey Rhodes said many years ago, it's very important that whatever we do in the medical field or whatever we do in the scientific field, that reaches out to the decision makers. Because at the end, if the governments, if the ones who have to decide are not aware and are not sensitive enough for this type of issues, nothing will happen. We've had many documents, we've had many calls to action, and we really need here to have the engagement of who has to decide based on the evidence. We have enough evidence today to move forward. Today, we've seen several presentations, and we just saw very important ones that give us all the evidence that we need to move forward for a strategy that should include early detection. It's clear now, there is no question about it. It saves lives. So it's a call to action now to save lives and save lives of children. And this is something that has to be highlighted. And you just saw the numbers. It's appalling. We are basically, by not doing the right thing, and by only having like 10% of people diagnosed, we are actually letting our children die. And that's not good, of course. I think everybody will agree with that. So it's really important that as we as medical community and scientific community that actually see when things go wrong and develop the science that can then be used to base on important decisions. What we can do here is actually to show very clearly what can happen if the measures that need to be put in place are not done appropriately. It's very important that now within the EU, there is this sort of consensus, and I think, and we saw presentations from different countries, and although there are still some inequalities among the different European countries, but I hope that this will be a very important push forward in terms of having a more homogeneous approach at European level. But not only that, and as my colleagues just mentioned, it's very important that these, I would say, simple measures to do this as we do today for some other diseases. I think it's clear that the early detection of FH should be like we do for hypothyroidism or for other conditions that are done in the newborn. And very nice experiences were shown and examples were shown here, still very small. And that's what we have to do now. We have to make this big. So we have to make this big, on one hand, the news that should reach the decision makers, and it seems that it's reaching there. And then make sure that from an operational standpoint, this can be done at the global level from low, middle, and high-income countries. It's very important for the future of our community. It's very important for the future of these people. Professor Ray just mentioned and I used this comparison also of the pension. If we all of us trying to save some money for when we are older, come on, here we're dealing with children, and we're dealing with the opportunity to not, an old concept that no one should be left behind. And I think we all agree with that. WHF has been doing its share. Many of you and many of the organizations represented here are members of WHF. There have been some important documents. There was an important document, a couple of call to action actually, organized a couple of years ago with the FH Foundation. We've been also working with FH Europe, which is a member of WHF. We've been working with many of our other members. There is now, we have at WHF organized what we call the roadmaps, and there is a roadmap on cholesterol, which is being updated, and actually Professor Ray and Professor Santos are the co-chairs for this roadmap. And I can only hope that all these messages, and that's why this meeting is important, because it's not only among doctors or among health professionals, it's also including many other players, and particularly the decision makers. So I hope this can make a difference for the future of these people, and basically for the future of all of us. Thank you so much.
Thank you so much. I'd like to echo your sentiments. I hope today is the day we go forward. Now, another major stakeholder is the European Society of Cardiology. So I'd like to ask Professor Halle about his perspective.
Dear colleagues, thank you for this great initiative, and also for the presentations. The only question I have is why stakeholders go out and do it. Why have you waited? Why are you waiting? The evidence is so clear. It is so simple to go for this, to save lives, as Professor Fausto Pinto pointed out, save lives of children. Who in politics, who in governance has the opportunity to save lives by action taken? So I just want to say from the European Society of Cardiology and Preventive Cardiology, just do it. Why don't you do it? Just do it and go for it.
I certainly hope so. Thank you so much. I also want to hear from Dr. Gutierrez Iberluze about what he thinks.
Yeah, first of all, thank you very much for inviting me, and also thank you very much for this initiative. That is, I think it is very on time. So Professor Halle was saying why we are not doing. I think it is quite clear why we are not doing. First of all, because no governments have decided to go ahead. Probably one government as a single voice would have said, we will go ahead and do it. Probably that will be also an echo in different governments all over the world, especially high-income countries. The second thing it is, we are talking about the saving lives of children, but in reality, it is making an action that will be, the results will be in the future. It will not be immediately. So we need to think about the politicians that they need to make the investments, and they wanted to achieve those actions and those outcomes to be measured in less than 4 or 5 years. One of the problems with most of these screening tests, it is that we test now and we have the results in 20, 30 years, at least in most of the cases. If it would be to have an action that will have an immediate effect, probably that will be ready right now. So why we are not doing? First of all, I talk with some colleagues that are health economists. I move in the area of health technology assessment, and they said to me, most of the public health interventions, and this is one of the public health interventions, if they are effective, they are cost effective, and as it has been demonstrated today. The second thing it is why we are not doing it. First of all, there are two movements by which, or two criteria by which screening programs are put in place. So the first thing it is acceptability. I think this case it is fully acceptable. So that means that most of the patients and in this case in the families, we are at the very beginning we are not talking about patients. We are talking about children. So and the families will accept that. And the second thing it is affordability. So making an analysis of which could be the cost of first of all providing the test, and second, structuring a program that could include the registration of the cases. I don't think it is not affordable by most of the systems, even in middle-income countries. So the issue is, once again, it is affordability and acceptability, and also showing to the decision makers that they are going to achieve something in the future, but that the countries, the regions, or the systems, they will be thankful for what they have done. So I'm very grateful to be part of this panel. I'm very grateful that we have a challenge ahead. That it is something that is first of all achievable because we have the test, we have the population, we have the outcomes that will be done in the future, and we have also the way of management to change the future. So on that basis, I would say the same as Martin Halle. So please go ahead and please convince politicians. Obviously, HT Evaris will have something to say in this regard, but please convince with data the politicians or the decision makers in terms of making the investment.
Thank you very much. You come to a very important point about convincing ministers of finance about the cost effectiveness of the screening programs. So how would you suggest we go forward and do it? Let's go back to Professor Ray and do the whole round, please.
Thanks, Lali. So I think, we have to think, when we think about this, there are those already in adulthood who are much more advanced, walking around, and it's those silent voices, if you will, and waiting for bad things to happen. Some of those, as you saw early, will be found through opportunistic testing, because now every time somebody has a test of some sort, they're often having cholesterol measurements. So there's a program around that. We need to make sure that when people go into hospital early on, we find those people, particularly when their cholesterol levels are high. So there's much more in that area that we also need to think about. But then you've got those people yet to be born, where or children, where actually we can do the most good. And I think what we've got to agree today is today, let's at least agree what good looks like, what we should aim to do. That does not mean that every country has to tomorrow or overnight invest in a certain amount to put it into practice within a year. No, each country can look to implement what good looks like at a steady pace that over a period of time provides affordable, sustainable policy implementation. But let's not argue what good looks like. We do know that child-parent screening can work, and not only can it work, is that it is cost effective. You don't do that and do that only and exclude all of those other people because you won't find them necessarily. So there are plenty of opportunities for cascade testing of adults, opportunistic testing, wherever that happens. But what we're talking about is that investment now by starting at the root source. For the future, we should be able to completely make the life or the lives of everybody born with this condition forever so much better. So let's at least agree what good looks like.
Thank you so much. And Professor Santos, for low to middle income countries, it's especially a challenge to convince the ministers of finance or health to move forward. So any suggestions?
Yeah, it's a good question indeed. Actually, I think first we must tell the politicians that FH is a disease that starts from birth, and really the most affected people will have heart attacks, who might die, actually are young people. So the data that has been shown that 13-fold increment on the risk of myocardial infarction or coronary heart disease between the age of 25 and 39. I think this is extremely important and remarkable. The second thing that we need to tell the politicians and people who really administer our health system is that we can make diagnosis of FH with very inexpensive tests. A cholesterol test is cheap. Okay, you might say, oh, you might need advanced genetic techniques and so on that might cost a lot of money. Okay, but we don't need that. Okay, if you have genetic tests, it's great, right? But not necessary, especially in low-income countries, okay? And third, the therapies that are available are not expensive anymore for a long time. They're all generic medications. They cost pennies. And they can make a lot of difference if we start using them very early. I think these are the three pillars that really need to bring and try to convince the people who really can make the difference and run the systems in order to make diagnosis and in order to start therapy and to prevent early disease. That's how I see it.
Professor Pinto, any additional suggestions on how to go forward?
Well, I would say that, again, here is the issue of communication and to provide the data. We have tons of studies showing the cost effectiveness on the treatment of hypercholesterolemia or dyslipidemia. So there is data, there is evidence. It's not lack of evidence. We have that. And particularly now, in this specific group of patients with the familial hypercholesterolemia, actually, we have a strong argument, which is about the workforce. We're dealing here with a very young population. It's children and young adults. So here we are dealing with basically removing workforce, early workforce from the population. One. Second, the fact that we treat these patients, we actually avoiding that these patients develop complications, meaning hospitalizations. And all of these, of course, and we have a health economist here, is included when you do all these studies. So if there is a population where cost effectiveness can be easily shown, and it has actually been shown, it's in this population. Because these are, and not even mentioning the emotional fact that we are dealing, particularly if you look at children, we are dealing with children's lives. It's not nice to see a 5-year-old having an acute myocardial infarction and having, as was shown today, and having sudden death, because it was not known that he had this condition and he was not properly treated. So I think we have more than enough arguments, more than enough evidence, even cost effectiveness studies that can clearly show the advantage of identifying these patients and convincing also the ministries of finances, even if they think on short term, even that will be enough to sustain implementation of measures to do early screening. And as was mentioned by Professor Santos, it's not expensive just to do a simple screening for high cholesterol, because basically we are identifying the small group, or relatively small group of people that then may need more complex studies and more expensive. And keep in mind, this is also a society decision. As a society, do we want to invest more on health, or do we want to invest more on other issues? And I'm not going to mention those, because this is also a societal problem, and that's where the politicians and the decision makers have to make decisions. But we have data, and we have data to support implementation of measures such as what we are discussing here, which is early screening of these patients.
Thank you. Professor Halle, any further suggestions for Europe?
Definitely, because I would like to address again why. I mean, we do have screening at birth and in children all along for different other diseases, hypothyroidism, phenylketonuria, and others. Why not do it for cholesterol? There's no reason why not to do this. And the cost-effective issue is not an issue, because for these others like hypothyroidism, phenylketonuria, there's also the cost-effectiveness is not the issue; it is saving lives. So this is the money issue, although it's very low. The money issue is not an issue. It is saving lives. Thank you.
Thank you. Dr. Gutierrez Ibarlucea, I know you have to leave shortly, but would you like to make any final comments before we close? Any suggestions?
Yeah, I think we need to learn from how other screening programs have been established. So, which was the basis for establishing a screening program at the population basis on breast cancer, or colorectal cancer, or trisomy 21st, or in most of occasions, so those that have occurred in the case of children, for example, the screening programs for deafness. I think we need to learn how they were implemented and why they were implemented. First of all, I think it is a policy statement. I think it is crucial, and also to share that with governments. Second, to establish an international scientific, I would say, conference in which the figures are shared with the community, but also with politicians, and also that they establish how to put in place a screening program, which are the type of tests that will be required, which are the cutoff points that will be defined, and also which could be the possible cost for each of the countries. And on that basis, decision makers and investors, they will have a chance to look at that. And also to try to reinforce one of the things that I've said before. It is, if one country starts, probably it is a movement that will create like a domino. So every single country will also implement the screening program. I wanted to thank very much for being able to meet in this panel. So interesting, and I look forward to also help in implementing the screening programs on familial hypercholesterolemia in Europe and in the world. Thank you very much.
Thank you so much. So everything we've spoken about in this panel is achievable with the right political will and smart investment. And I would like to thank all the panelists for their contributions, and really hope that today is the day we move forward. Thank you very much indeed.
And thank you, Lale. Thanks very much to you. The session really underlined there's a clear consensus about FH pediatric screening, why it makes sense and why it has to happen now. Science, partnership, data, know-how, urgency from both a human and an economic perspective are all really key.